Very good evening, everyone. A very good evening, ladies and gentlemen. Welcome to yet another amazing session from Online Dentistry. I, Dr. Devika Vaswani, wish you happy 75th Independence Day on behalf of the team Online Dentistry. Kindly wait for another 2 minutes while we enter all the participants. For any inquiries, you can visit our website www.onlinedentistry.in. Before we start the session, I'd like to give my big thanks to all of you for the support that you have shown to online dentistry in all the webinars. And let's just go on introducing online dentistry. Let's see how it started. This was just a short glimpse of what online dentistry has done so far. Our motto is to redefine dental education and take it to greater heights. Our numbers suggest that online dentistry was established way back in 2008. The total number of offline classes that were taken are 122, but the total number of online courses are 500 and plus. We can proudly say that we are a global family of 20,000 people and more. Our esteemed mighty founders of online dentistry, Dr. Joby Peter Sir, Head of Academics, Professor, and Head of the Department of Pediatric and Preventive Dentistry at New Dental College, Kerala. And Dr. Binuti Abraham, the Speaker of the Day and the CEO of Online Dentistry, Kerala Dental Clinic, Alua. Well, online dentistry is always jam-packed with sessions coming up, and we have a lot for you as well. On 29th August, we have an amazing session from Dr. Jos Paul Sir of Periodontics for General Dentists. It will give you all the tips and tricks that are supposed to be needed in the clinics. Coming to the next amazing session, that is all about expansion by none other than Dr. Jobby Peters, sir. This will explain you A to Z about how your kids needs an expansion, SME, RME, all of it. Coming to one more on public demand conducted session, oral habits demystified. This highlights the importance of early diagnosis of habits and its consequences. So ladies and gentlemen, do not miss these webinars. For any queries and staying updated, please call us on these numbers or WhatsApp us on these numbers in order to get added to our groups. Now, without further ado, I'd welcome all of you to today's session, that is Expanders in Daily Dental Practice, how small things can do big effects. Introducing Dr. Vinuti Abraham is my great privilege today. He graduated from the College of Dental Surgery, Manipal in the year 1995. Later on, he went on to New York University to do a postgraduate diploma in orthodontics. After post-graduation, he worked in New York as a faculty in the Department of Orthodontics, senior lecturer in CODS, Manipal, and faculty in Ajman Dental College, Ajman. Currently, he is in private practice for the last 21 years, owns a state-of-art dental clinic in Kochi, Kerala. The primary area of focus is early age orthodontics, clear aligners, etc. He is the CEO of our firm, Online Dentistry, which is dedicated to continuing dental education in various topics. He is an active member and faculty of International Association of Orthodontics and conducts classes for pediatric dentists and general dentists in various platforms. He was the keynote speaker for the South Asia Pacific Association for Pediatric Dentists and the only Indian faculty for the World Dental Conference in San Francisco. He got the top 10 Best Paper Award in the Greater New York Dental Conference on the topic Orthodontic Mini Implants. He was a keynote speaker for ISPPD Raipur, Chennai, Meerut, and etc. He is an active member of International Association of Facial Growth Guidance, specialized on orthopedics, International Association of Orthodontics, and Fellow Academy of Inline Dentistry International. Apart from that, he is a great orator and amazing speaker. I welcome you to this amazing session of Expanders, sir.
Thank you very much. Thank you so much, Dr. Devika. Can I share my screen?
Yes.
Yes, sir.
My screen visible? I'm audible too?
Yes, sir, you're audible. Your screen is visible as well.
Thank you very much. Young couple was cooking together, cooking sausages together. The husband noticed that this wife is cutting both the ends of the sausage and wasting so much sausage. He was like shocked. I mean, why are you cutting both the ends like that and wasting so much sausage? She said, hey, that's the way I was taught. He was not happy with that answer from his wife. I mean, he thought she would say it would enhance the flavor of the sausage and all that, but she said, that's the way I was taught. He was not happy. You know what he did? He went and asked his mother-in-law, that's his wife's mother, hey, do you have this habit of cutting both the ends of the sausage like this and wasting so much sausage? Oh yeah, that's the way I was taught. Now he understood that this is something which is going on for generations. But he was curious. He was really curious. And he wanted to go further, one step further. He went to the grandmother-in-law, asked her, you know what, have you taught your daughter and your granddaughter to cut both the ends of the sausage like this and waste so much sausage? Yeah, that's the way I was taught. he rested the case there. He said, okay, this is enough. This is something which has been going on for generations. He rested the case there. After a few months, this grandma came home to visit this couple. Grandma went into the kitchen to saw this couple cooking. And grandma was so surprised and shocked to see that granddaughter is still using that small little frying pan used by grandmother years before, transferred generation to generation, and she's still using this. Oh my God, you're still using my old frying pan. I'm so happy to see that. And she said one more thing. You know what? This small little frying pan is the reason why I had to cut both the ends of the sausage to fit into the damn frying pan. Guys, we have to get out of this concept called that's the way I was taught. We dentists have this habit. We charge according to what your seniors charge. We charge, or we do everything in the clinic according to what your seniors have been doing. That's the way I was taught, is the answer for that, all that. It's time to upgrade, guys. It's time to get a bigger frying pan and go forward. You see a crowding of this kind with severe crowding, laterals has no space. You extract premolars and say that's the way I was taught. You see another case with severe crowding, no space for lateral, no space for canine, and you say you extract teeth and say that's the way I was taught. Why are we not thinking differently? Why are we not looking at the arch and expanding the arch, creating space? If these two canines, look at these two canines, if these two canines can be expanded and brought into the arch without extraction, guys, we need to talk about expansion. We need to talk about expansion. Good evening, one and all. Welcome to Online Dentistry's yet another program on expansions. Free webinar by Online Dentistry on expansions. And happy 75th year Independence Day to one and all. We need to talk about expansions. Let's start with a patient, 13-year-old male, complains of crooked teeth, severely crooked arch, cross bite, no space. Patient is in front of you. Now you look at the occlusal view, guys, we've got to have an idea about something called as intercanine width, intermolar width. You have to have a chart in your clinic. You can take a screenshot of this if you want. Chart in your clinic with the normal intercanine, intermolar width, this is intermolar width of every ear. The 3-year-old intermolar width and a 13-year-old intermolar width is obviously different. You got to have a chart, compare it. Let the patient come in, look at the intermolar width, look at the chart, and ask the patients, tell the patient, see, there is a problem. Your arch width is very low. Are you doing that? If not, do that from tomorrow morning onwards, guys. You don't need too many rocket science knowledge here to do that. Just have to have an idea about the intermolar, intercanine width. Then photo analysis. How many are taking photographs? I don't know. Take a photo. Look at that mid face of the patient. Don't you think it's a little flat already? Already a little flat. Now you take out 2 teeth and flatten it further. You're going to just worsen it, right? Have a look at the photographs. Photo analysis, so very important in your early age orthodontic diagnosis. Cephalometrics. Oh my God, this fellow is going to talk about cephalometrics and all that. We hated that right from 3rd year. And I didn't take orthodontics because of cephalometrics. Guys, every general dentist, forget speciality here. You got to have an idea about that basic concept called anterior arc and the position of the anterior nasal spine. You know, anterior nasal spine, come on, you know where it is. The anterior nasal spine has to fall on the anterior arc. If it's way behind, means maxilla is way behind. You got to do something about it. Maxilla is way behind. It's proven with your cephalometric analysis. Photo analysis showed there is a deficiency. Cephalometrics confirmed there is an ANS point behind. ANS is, for info, that anterior nasal spine formed there. I don't want to go into the anatomy and all that here, but it's so important to know the position of anterior nasal spine. Expand with a rapid palatal expander. Split up the mid-palatal suture, expand it, create space. Look at the amount of expansion. Look at the amount of mid-palatal suture opening up, which we got. It might look a little ugly at this stage. But let me tell you, 8 out of 10 patients that go through this, you know what parents have told me? Hey, Dr. Binu, this is too big a gap. It's looking a little ugly. But, doctor, my son is not snoring anymore. Is it something related to what you just now did? I don't know. He was like such a heavy snorer. And he was such a disturbed sleeping person. He's like sleeping properly. Did you do anything for that? I'll come to that soon. I'll come to the importance of rapid palatal expander and its significance in improving the airway soon. So expand it, do your orthodontics, do your conventional orthodontics, go ahead with your orthodontics and create a better arch for the patient. Intercanine, intermolar width, beautifully placed so that you can get all the teeth into the arch. Now look at him after treatment. If you actually really look at him, his after mid-face is still little deficient, I would say. I'm not very happy, still little deficient. So just imagine if you had extracted, it would have been a total disaster. So that demarcation, when to extract, when to expand, so very important in private practice. Patient number 2, 13-year-old female, before it was 13-year-old male, it was 13-year-old female with a crowded arch. No space for the canines. If you look carefully, it is so difficult to take the picture, occlusal picture. If you look carefully, I can see 2 canines there. I don't know whether you can see it. Deciduous canines are there and the permanents are out there. 13-year-old female. You do your model analysis, individual teeth measurement, intercanine, intermolar with palatal depth, so important. Understand all that. Come to a decision. Photo analysis, look at the profile. Maxilla is actually, if you look carefully, upper lip is slightly behind, just like the previous case. But you look only at the dental and extract teeth and align everything. You're not doing justice because there is maxillary deficiency there. ANS point is behind. So this case should not be extracted. You should go for expansion. Fan-shaped expansion. What is the difference between fan-shaped and the earlier one I showed you? Fan-shaped expands anterior more. So if this case can also get more than enough space for the canine to come in by something called as fan-shaped expander, which expands primarily or more in the anterior area than the posterior area, because posterior intermolar width was pretty much normal in this case. And those canines got space to come into the arch. Guys, I just covered two types of rapid palatal expander: Hyrax, conventional Hyrax, and then a fan-shaped expander. Two types. Conventional Hyrax expands the whole arch. Fan-shaped, more anterior. But end of the day, let me tell you, we are doing a skeletal expansion of the maxilla. So, what is this rapid palatal expansion? What is this simple key and turning like this, changing the life of the patient? Changing the life of the patient. I'm coming to that pretty soon. You guys are looking at the arch, how I expanded, how I got space for the canine. I'm talking about changing the lifestyle of the patient. I'll come to that. So, what is this simple turning going to do on the patient? You turn one time in the morning, one time in the evening, every day, one time in the morning, one time in the evening. You keep turning. You can see the arch becomes wider. How the mid-palatine suture literally opens up. For that, some amount of growth should be remaining. But I'm going to talk about a little bit about adults also going through this. Okay, so don't worry, we have time. So this is rapid palatal expansion. You're playing around with your maxilla. You're playing around with the maxilla. You got to know the complete maxillary anatomy. And you have to understand that you're splitting the maxilla, V-shaped splitting up of the maxilla. It's orthopedic changes happening here. V-shaped splitting up of the maxilla. Proved by an occlusal radiograph. After expansion, take an occlusal radiograph, you can see that. If you don't want to send the patient out to an occlusal radiograph center, take an IOPA, your digital RVG or your IOPA film, and put it 60° with the cone from the top. You can prove that with an IOPA that the mid-palatal suture has been opened up. This is skeletal expansion we are talking about. There are posterior anterior analysis, PA view analysis available in cephalometrics. Oh, this fellow is talking about cephalometrics again. We're fed up with the SNA, SNB and all that, lateral ceph analysis. Now he's talking about PA view analysis, new analysis in orthodontics, where there are proofs that once you split up the mid-palatal suture, expand the maxilla, you are actually increasing the airway. You're increasing the airway. There's proof. Articles are there. I don't have the habit of putting articles into my lecture, but let me tell you here, in the website, onlinedentistry.in, www.onlinedentistry.in, go to the website today after the class, go grab those couple of beautiful articles I have kept in the website, which proves that by rapid palatal expansion, you are actually improving the airway of the patient. ENT guys are going to be more happy than you. Now, if you want only anterior expansion, you have to use this fan-shaped expander. Fan-shaped expander, look at that. This is the case which I showed earlier. It's just a sketch of it. The intermolar width is actually pretty much normal or more, I would say. So you have to use a fan-shaped expander in such cases where you can get expansion only in the anterior area. That's called a fan-shaped rapid palatal expander. And this improves the sleep. Yes, there is proof. I've kept an article on that also in the website, which proves that it improves the airway and it improves the sleep. Every patient coming into my clinic, especially pediatric cases, pediatric orthodontic cases, I make sure they go through this form filling. It's called Epworth Sleepiness Scale. I've covered this form in the bruxism classes for adults and all that. Beautiful form. Basics of sleep study. pure basics of sleep study, not the polysomnogram study and all that. Yeah, I'm talking about a questionnaire. Give this questionnaire to the patient. Let them answer it, tick it one by one, give marking and find out his sleeping pattern from this questionnaire. I have the whole prescription pad. I just take one thing and give it to them, fill it and give it to me in the next appointment. And so happy to announce that Online Dentistry technical team has agreed or has done the procedures for you guys to go and collect this ESS form from the website. You can download it, you can print it, make the prescription pad if you want, A4, A3, or small ones if you want, and give it off to your patient. Every pediatric case that comes in, especially with constricted maxilla, especially with the patient saying she's always having cold, she can't take ice cream, such kind of cases, get the ESS score. You will get an idea of what you're dealing with. Guys, what I'm talking about is having a bigger frying pan. Coming back to the same sausage thing, you got to think wide, you got to think broad. We are not just doing fillings and cavity fillings and all that, guys. We are way above that. We are doing orthopedic correction. We are changing the lifestyle of the patient. And the ANS point, which I told you, is coming forward. By expanding, you can see ANS is coming forward. Can you believe that? And one article I've kept in the website proving that ANS point is coming forward just by expansion. All you did is a transverse expansion. But that transverse expansion gave a sagittal forward thrust because airway improved. That is a proof of airway improvement here by expansion. So guys, we are dealing with an orthopedic stuff, changing the lifestyle of the kid in front of you. Understand that. So let me summarize rapid pedal expanders here. Take a little more than needed time on RPEs. RPE is nothing but rapid pedal expansion. You do daily twice turning, one in the morning, one in the evening. That kind of rapid movement you do. So rapid that when you do the turning, the forces are on the teeth, obviously, right? You know that the forces are on the teeth. Why the forces are on the teeth? Because the bands are attached to the teeth. So first force is on the teeth. But before even the teeth can think about a dentoalveolar expansion, the suture opens up. So that's called rapid palatal expansion. The forces are so high that before the teeth can go for a dentoalveolar, the suture opens up. Then the suture takes over. This area takes over, the whole maxilla splits up. You won't get any more dentoalveolar. So that's the difference in this rapid palatal expansion. Forces are so rapid that you get a skeletal expansion. You're basically opening up the mid-palatal suture, getting the skeletal expansion. ANS point coming forward and airway improvement. All this articles are there for those postgraduates listening to me. Please read those articles. You'll get a good idea about what I'm talking about. There are some more types just to complete my RPE. The one on the left is a banded one. Band on the molar only, not on the premolar. Not very good. Try to band on the premolar whenever possible so that you get a little more stability. And the other one on the right side is a bonded one. Bonded one is with an acrylic bonding altogether so that the whole thing is engaged in there. The much better anchorage, much better hold. But there is a problem that the bite will be open. That is okay for certain cases. We have to look at the vertical component also before going for a bonded type. Now, some precautions to be taken. Let me tell you from my personal experience, the most important precaution to be taken when you do a expansion is that screw, that key patients following. Very, very important. Key comes like this. And there are multiple companies giving keys in holders like that, and with a hook and all that. Whatever you do, you have to hook it onto teeth or use a floss and connect it onto your finger. This is not you. Understand? This is done by the patient. Patient is doing this, or the patient's father or mother, or obviously it's going to be patient's father or mother doing it. It is your responsibility to make them aware about the seriousness of this. And let me tell you, it happened in my clinic. 22 years into practice, I've seen all this. It's happened in my clinic. Patient swallowed it. Under general anesthesia, it had to be removed. So be careful. Tell the parents to be strict about this turning. At turning time, let the kid lie down perfect 45-degree like that, with the mother with the torch, father with the key. It should be a teamwork, guys. There's practice management also there. It's not like father in phone call and doing this and all. That crap won't happen here. Yeah, you got to be serious. How serious you are is how serious parents are. So please make sure you take this seriously when it comes to the precautions of it. Next, slow expansion. Slow expansion. These are some of the appliances to be delivered tomorrow because it's an Independence Day expansion devices. Guys, pediatric cases, yeah. Tell your lab to be very innovative. August 15th. So delivering yesterday, delivering tomorrow. All these cases has to have a color combination. Anyway, this is slow expansion. Slow expansion is very slow. So slow that we are getting only dendo-alveolar expansion, no skeletal expansion. And if you look carefully, the label bow is not a conventional label bow. It's more of something called as a Roberts retractor, which has a loop so that as you widen, this also expands along. And how you do that? Ask the patient to remove it, and outside the mouth, they can just turn it. Into the direction of the arrow. You can see a yellow arrow there. Into the direction of the arrow, you can just turn it. One turn on Monday, one turn on Thursday. You're talking about 2 turns weekly. Rapid palatal expander was what? Daily, morning, evening. This is 1 turn on a Monday. After 3 days, Thursday or Friday, 2nd turn. You're talking about weekly twice. So slow that there is nothing called opening up of the mid-palatal suture. It is just dendo-alveolar expansion. Look at this pediatric cases. Thanks to Dr. Joby for sharing me these pictures. These are his cases, but done in my clinic. This is a case of slow palatal expansion. With this appliance, this is the kind of expansion you can get, kind of space you can get, but dendo-alveolar. Another case here. Look carefully at this case. Okay. Look at the palate of this case, before and after. Look at the palate. And now, come to the chat box, or it's my customary style to ask them to come to the chat box and type something which I never did up to this time in this particular class. So come to the chat box and can you comment something you see or you notice about the palate of this case before after? Palatal depth, deep palate. Width increased, obviously, yes. V-shaped into U-shape, high vault palate. Good. If you look carefully, with that expansion, With that kind of expansion, this is an expander, and that's the amount of expansion we got. And after expansion, you seal the screw with the composite or acrylic and close it so that it doesn't rebound, it doesn't come back. Yeah, that's a retention stage. I just covered the retention stage also. After expansion, seal it, seal the hole, everything with composites or acrylic so that the patient cannot turn anymore and the screw cannot go back anymore. But look at the depth of the palate. That palatal vault has become shallow if you look at it. Why? Why did it become shallow? Because the moment you start expanding, the tongue starts going up. Here you have to do the cephalometric analysis on tongue positioning. How many look at the cephalometrics for tongue positioning? Tongue has to be up there on the palate. Moment you give space, tongue will automatically go up there. The palate becomes shallow there. That's the tongue going up. Just because you use space for the tongue. Without giving space, asking the patient, put the tongue up there. Do the exercises, tongue exercises, whatever you tell them, they can't do because there is no space for the tongue to go up because of the constricted arch. There's one more thing to look at, tongue tie. How much of a space you give there, if the tongue is tied down there, they can't take it up. So cut the lingual frenum. So this is a correlated thing. It's a holistic approach we are talking about. Just want to complete that slow expansion by talking about fixed slow expansion. Fixed slow expansion, which is called quad helix. Quad helix is one of the most accepted, approved stuff all around the world, which is a fixed slow expander, wherein you can get dentoalveolar expansions exclusively for anterior, exclusively for posterior, because it has two helix, anterior helix, posterior helix. So depending on the way you activate, you can get more of anterior, less of more posterior. More of posterior, less of anterior, depending upon how you activate a fixed quad helix. But end of the day, let me tell you, this is also a slow palatal dentoalveolar expander. Adult open bite. How many times have you seen a 35-year-old guy coming into your clinic with an open bite? Actually, it's very common. I've seen celebrities. I don't want to tell names here. I've seen celebrities. Recently, I saw an interview, big time celebrity. But when she speaks, so I would like to look that the tongue just comes there like that. She's a celebrity, but there's an open bite there. But she's supposed to be very famous. So what I mean to say is adults have open bite, and this open bite has produced a phonetic difference also for them. So adult open bite, look at this case, adult open bite. Even for a 35-year-old, you can give a slow palatal expander and give little more space for the tongue and do some tongue training and get the tongue up. Guys, it works wonders. Little bit of expansion and that tongue training exercises. You will have to refer back to Dr. Jobby's lecture on myofunctional exercises, tongue therapy, tongue exercises and all that, myotherapy part. Lots of videos, lot of lecture, free webinars conducted by Dr. Jobby on tongue and its role in molding the whole face of the patient is Dr. Jobby's favorite topic. I'm just showing a 35-year-old and look carefully at this before and after. Look at this before and after. I haven't done big things, I know, but for the patient, his phonetics changed, His lifestyle changed just because he started swallowing differently, just because he got his tongue up. That is the beauty of these kind of treatments. So let me summarize the types of expansion I just covered. I just talked about RME, which is rapid maxillary expansion, SME, slow maxillary expansion, also called as RPE, rapid palatal, SPE, rapid slow palatal. And for completion's sake, I just want to talk about two more things, SARPE and MARPE. SARPE is nothing but surgically assisted rapid palatal expansion, surgically assisted RPE. So you got to surgically, under general anesthesia, surgically leaf out, open up, and then expand. Same expander can be used, but surgically you are cutting it, including the mid-palatal. It's an adult we're talking about, including the mid-palatal and the leaf out. One, we are opening up and then using the same screw, which is called surgically assisted rapid palatal expansion. Very common, very common. Then the MARPE. MARPE is mini implant assisted rapid palatal expansion, mini implant assisted RPE. So you put mini implants on the 4 screws here. You can see my mouse here. You can see mini implants on the palate. So even if the kid is like 15, 16, 17, you can still give a try because forces are so heavy, you can crack open. That's the terminology used by the professors in orthodontics. You can crack open the mid-palatine suture with mini implant assisted rapid palatal expansion. That's MARPE. Just want to complete the session on expansion with this. That's it. It's time to conclude now. Let me conclude my session. I overshoot my time already. Sorry about that. Let me conclude with one final case I want to present here. This patient came to me when he was 9-year-old. 9-year-old mixed dentition, single tooth and cross bite. Single tooth and cross bite. Obviously, I told you got to go for an expansion. Is that spring, correct the crossbite, or 2x4, correct the crossbite. All sorts of typical conventional things which we said. They went for second opinion, third opinion. As a matter of fact, they came to me as a second opinion. Listened to me, but didn't obey to me. They didn't want to do any treatment. They went somewhere else. I found out later on that they went to multiple other clinics inquiring about this small device called slow palatal expander and an Z spring to bring that crossbite correction. That's all I said. Something like 2,500 rupee treatment plan. Yeah. But the parents did a lot of inquiry and they never did that. Now, let me tell you, since I'm into my 22nd year of private practice, same patient, and I have records for all my patients way back from 1999. Same patient after 10 years, when he was 19 years, he came to me. He came to me when he was 19 years without parents. Doctor, do you remember me? I had come when I was a young kid. This is him, 19-year-old. Severe long face and severe midline, complete deviation, all because of that crossbite at that young age. And there's no point in telling, I had told you at that time to go for an expander. There's no point. He's not going to remember all that. So what happened to him? I had to go for a complete orthognathic surgery with my orthognathic surgeon and get his midline, the deviation, everything perfect. At the age of 19 years, I could do, not me, my orthognathic surgeon, with, of course, orthodontics, we could get him a perfect midline and all that. But he has to live with these screws the rest of his life. And 10 years before, the treatment plan I told was like 2,500 rupees, and this treatment plan is like 2.5 lakh rupees. So forget money part, guys. I feel it was my failure at the age of 9, my practice management failure, not making the parents understand the significance of all this. I consider it as my failure. I mean, they went to multiple clinics. I know all that. Still, I feel if I had convinced him, that small little crossbite at the age of 9 years, he wouldn't have had to go through all this stuff. That is why I'm concluding with this case with the statement, it's time to change that frying pan. It's time to increase the size of the frying pan. It's time to look holistically. And we as online dentistries committed to these kind of programs. Fourth time we are repeating it, or maybe fifth, I don't remember. Fifth time, I guess, we are repeating this program all about expansion. Right from the beginning of the pandemic, 2020, April, we conducted this expansion, conducted it at least 4 or 5 times, if I remember correctly. Due to popular demand, we are doing this again, all about expansion, coming about 29th August, Sunday, 1 full day. But this 1 full day, if you're planning to attend, please make sure you are ready for a long session, hectic learning session. It's a 1 full day program. We're going to talk about detailed diagnostic protocols. If you think that we are going to just teach you how to take an impression and put an RP or an SME, no. We are going to teach you 1 full hour on photograph analysis alone. Hands-on photograph analysis. One of its kind ever happened in the online scenario. We have done it 4 or 5 times. Many people are doing RPs and SMEs after a program of this kind. Hands-on photograph analysis, hands-on model analysis. Can you believe that? All registered candidates has to have a model with a divider scale, all that ready. They have to measure individual teeth. They have to measure the intermolar, intercanine, the depth, everything, and come to a diagnosis in front of Dr. Joby. That is the kind of hands-on we are talking about, not just lectures. And then hands-on cephalometric analysis, which I am going to deal that day, almost an hour or a little more on archial analysis, exclusively proving the importance of ANS point with the anterior arc and how to bring it forward. All that will be covered systematically on that 1 full Sunday. And then complete details of SME, when to go for an SME, when to go for an RME. And then from impression taking to the delivery, all the practice management part, and then after all the expansion, how to retain it. Everything covered 1 full day. Bottom line, guys, it's time to change the generation-old concepts of using the same old sausage and same old cutting both ends of the sausage, guys. It's time to change. It's time to look differently. It's time to look at different newer gadgets available and plan your treatment. Thank you so much for this crowd coming in for a topic which is not exactly relevant from tomorrow morning onwards, but I'm sure I could give some spark to this topic called as expansion. Thank you very much. This is Dr. Binoy Abraham signing off. Over to you. Dr. Devika, you're not audible.
Am I audible, sir? Now?
Yeah.
Thank you so much, sir. It was an excellent session. We also learned the value of unlearning, sir. Thank you so very much. We have a few questions, sir, regarding this.
Sure.
We have a question. In this case, expansion altered the cuspal contact between maxilla and mandibles. It was from some case, I think the 3rd case.
Wait 1 second. It's in the chat box or in YouTube? Where is it?
Yes, sir. It's from the chat box in Zoom, from Dr. Isha Gupta.
Just read. I can't see that. Just read the question once more.
Yeah. In this case, expansion altered the cuspal contact between maxilla and mandible. Question.
I don't know which case he or she is talking about, but as part of expansion, initially there will be something called as over expansion. You almost reach something called a Sunday bite, but there is a place to stop. There is a position to stop your further expansion, and then it will relapse and come back to its original biting position. And one more thing, when you expand the maxilla, mandible follows. Next.
Thank you, sir. Also, question is, will expansion create problems in the eye?
No, not exactly, but I have read some articles where too rapid, too much of turns has, see, with the moment you turn, even if it's one turn in the morning, one turn in the evening, as you turn, the kid might say some pain here, some pressure here, but within 2 minutes, they'll be done. So if you do a little too much, I've read about a little bit of strain to the eye. So that's a genuine question there, but not practical. I haven't seen that in my clinic. You got to go by the protocol. There's a turning sequence available by different authors, and the one I use is one turn in the morning, one turn in the evening for almost 7 days. After 7 days, you have a look at the patient, see the amount of diastema that has formed. If you get like 1 mm diastema, you are successful. That means you have opened up the mid-palatal suture. Then go for, again, one turn in the morning, one turn in the evening for another 7 more days. You're talking about a proper 6 mm, 5 to 6 mm diastema. So 14 days over. 14 days over, see the patient. And now you take the call. Should I go for little more over expansion or should I stop there? From experience, let me tell you, I normally continue turning for another 1 more week, but this time, the last 3rd week can be 1 turn in the evening only, not in the morning. So we are talking about a turning protocol for something like 3 weeks. In 21 days, 15 to 21 days, this whole concept of turning should get over. And Dr. Joby is going to talk Isaac Simmers and all that perfect methodology for turning will be covered, including the screw anatomy. How much exact millimeter is the turning as you turn will be all covered by Dr. Joby with lots of animations, that 29th program. Next.
Thank you. Another interesting question, when to do RME and when to do SME?
I didn't feel that question is very interesting. Anyway, see, SME is a slow one. So if you want only dendo-alveolar expansion, you choose an SME. Now, which age you want dendo-alveolar expansion? I told you I've done on a 35-year-old guy. I've even done on a 52-year-old female dendo-alveolar expansion just to create some space, just to get that swallowing pattern better. So SME is possible at any age. That's about SME. When it comes to RME, you're talking about opening up the mid-palatal suture. Opening up the mid-palatal suture, I would say, you have to be having some growth potential remaining. So 13, 14, 15 should be max. Guys up to 15, you can give a try. But girls after 13, 14, you got to look at the CVMI. All that is covered by Dr. Joby on the growth pattern, CVMI, X-ray analysis on the maturation index and all that. But I would say, practically speaking, 13 female, 15 male should be the kind of limit. But with Marpe, which I'm doing, a lot of Marpes I'm doing. With Marpes, I have done opening up an 18-year, 19-year. Many times it is assisting the surgeon. It is like helping the surgeon before the orthognathic surgery. I am just doing a Marpe. mini implant assisted rapid palatal expansion to create space so that surgeon can do the proper Le Fort 1 or BSSO depending on the condition.
Thank you, sir. We have another question. Role on expanders in open bite correction. How to manage?
Role on?
Role of expanders in open bite correction. How to manage?
That's a very good question. That's actually a tricky question. See, open bite and crookedness together, we are dealing with a little tough game there. And let me tell you one thing, whenever you open up the mid-palatal suture, chances of increasing the open bite is little more. So if it's already an open bite case and you are doing an RPE, you might increase the open bite. So be ready for correcting that open bite with your full-fledged orthodontics, including mini implant assisted open bite corrections. Be ready for all that if you're already dealing with an open bite case. Now, one clue I can tell you here is, from experience, the bonded type RPEs, the bonded with the acrylic bonding there, it interferes with the bite. It opens the bite further, but that is found to intrude the teeth so that the open bite gets little better corrected along with your expansion. So it's a very good question, but little on the next level, I would say.
Thank you, sir. What about expansion in mandible?
No, mandibular expansions are more of dentoalveolar, done that for creating little space for the laterals and all that. But the intercanine width of the mandible, if it is normal and you try to increase that with an expander, it will relapse whatever said and done. So you got to look at the intercanine width in the mandible and then decide whether you need to. So it's going to be purely dentoalveolar. There's nothing like opening up the suture and all that in the mandible. It's going to be a dentoalveolar, and those dentoalveolar expansions can relapse too much. So mandibular expanders to be used very specifically when you only need little bit of movement of the intercanine, little here and there, so that one lateral can come in, that is possible, but not like upper.
Thank you, sir. When to give banded and when to give bonded expansion appliance?
That's exactly why I told you two things. One, whenever possible, try to give a banded. That has the best anchorage possible, and that will not open up the bite at all. Very comfortable to the patient. But to give banded, you got to have your premolars fully erupted, molars fully erupted. So we are talking about age about like 11 and a half, 12 and a half. And the cases which you're going to get maybe like 9, 9:30, 10, 10:30, where premolar may not be even there. So that is the time we'll have to go for bonded. And another situation to go for bonded, I told you, is already open bite cases. You want some intrusions. These bonded ones really help in getting the open bite corrected.
Thank you, sir. Expanders to be used for anterior-posterior expansion, especially in class 3 MO with anterior segmental crossbite.
I didn't get the question. Say it again.
Expander to be used for anterior-posterior expansion.
Anterior-posterior expansion.
Yeah.
Okay.
Especially in class 3 MO with anterior segmental crossbite.
Oh, that cannot give a heavy skeletal correction because you're talking about the pre-maxilla being taken out. So it will be more of a dentoalveolar. You may not get the pre-maxilla expanded like that. So this is not mainly done for that anterior posterior. It is mainly transverse. But there is something called a 3D screw. Again, comes in slow palatal expansion, wherein along with this, you get a little bit of forward thrust also with a 3D screw so that the pre-maxilla also gets a little outside thing. but that is nothing to do with the rapid palatal opening up part.
Thank you, sir. Another question. What will happen to the opened up space in the mid-palatine suture? Will the maxilla be weak?
Will the maxilla be what? Weak.
Weak.
No. The opened up space, that is the midline diastema that is formed, will start closing within days, within weeks, with the transseptal fibers being so stretched. You can see automatically incisors start closing like this. And then with your straight wear ortho, you can get it uprighted and all that correctly. So it's not going to make maxilla weak or anything. It is only going to improve the airway. It is giving more space. And one last thing, whenever you want to bring the maxilla forward, that is in the protraction face mask, orthopedic protraction face mask, bringing the maxilla forward, it's always easier to bring 2 pieces forward than 1 piece forward. Understand that. So whenever you do a protraction face mask, it's always good to split it up, then try to bring it forward, rather than getting 1 piece forward. Hope I answered that properly. Those people are not happy with the answer, please come to the WhatsApp group and please comment. I will answer tonight itself, or by tomorrow I will answer all that. I know it's not very easy to cover their individual doubts, but I think I'm doing okay. Go ahead, next one.
Yes, sir. Will the diastema cause loosening of anterior teeth?
That moment of that first 21 days, if you start touching the central incisor, you might see it is a little mobile. Don't touch. Just do not touch. Tell them, do not worry. So it's practice management there. You put an RP and tell the parents that, you know what, within next 2-3 days, there is going to be a huge gap there. Watch out. Huge gap there. That is called success of the treatment. After 2 days, you start getting phone calls. Sir, I am looking at my son. There's no gap, sir. Is it a problem, sir? Okay, so now they are waiting for the gap to form. Other way around, if you don't tell them about this gap being formed, the phone call can be in a different angulation altogether. Doctor, what is happening? Doctor, my son is having a huge gap. He's looking so ugly now. So that is a different way to look at it. So that's practice management. Make them understand that within 7 to 8 days, if diastema is not formed, either your turning sequence is not going good, or we have failed in the rapid palatal expander thing. It's not working. So make them understand what you're trying to do. And the success of opening the mid-palatal suture is the diastema being formed. So if diastema is not formed, it's not success. And you can't guarantee success for every cases. It's a teamwork. Parents should understand what you are trying to achieve. Very important.
Thank you, sir. Another one is it okay to do RME in a 7-year-old patient?
RME in a 7-year-old, Dr. Jobby is there. RME in a 7-year-old is, I would say no, but we have done bonded. See, you can't put banded in a 7-year-old because there is no premolar, nothing. All you have is maximum S6, which is not even fully erupted. And then you have a D and an E, which may be carious or whatever. So all you can think about is a bonded one. So bonded RME on a 7-year-old and splitting up the mid-palatal suture, if you are doing, you are talking about a proper genetic class 3 case in front of you. Proper class 3. And you are talking about protraction face mask along with it. Just for the sake of little arch width and all that, 7-year-old, you won't do RPE. It will be all SMEs. So 7-year-old we have done, but it is more of proper opening up and bringing forward. So the expander will have 2 hooks here, 2 hooks to put the elastic for the protraction face mask. So that is a necessity when it's a proper, true genetic class 3 in front of you. But otherwise, 7-year-old is little early for RPEs.
Thank you, sir. One more question. When we use banded RME, do we need a posterior bite block?
Banded RME, posterior bite, no, you don't need. I mean, if you really need a posterior bite block, then you should be using a bonded RME, which has a bite block already. So there's no point in putting a banded RPE and then putting bite blocks. No, the bite will automatically open as the mid-petal suture opens up. The molar, the molar opens up like this. So it flares like this so that the bite will be slightly open already and go into a scissor. But don't allow it to go into a complete scissor. Stop it somewhere here. All that is covered beautifully by Dr. Joby. When to stop, when not to stop, all that will be covered in that program. So if you're interested to go to the next level, I strongly feel this 1 hour, 40-minute program is not the way to go. You've got to be attending proper programs on expansion. And believe me, there is no expansion program till date in the world. I'm so confident about it because we are in close touch with people like Derek Mahoney, sir. We are in close contact with Josh Jefferson, sir. Nobody is having a proper program exclusively on expansion. Even if it's there, let me tell you, it will be a program sponsored by some lab promoting their lab, their expander. So pure expansion program, 1 full day, one of its kind in the world. And that's why it has been repeated so many times. And we are doing that once more.
Thank you, sir. Is there any use of using coffin spring?
That is like, to answer that, I would say, will you still go back to a Fiat or an Ambassador at this point of time? Maybe as a vintage. What's a disturbance in between? As a vintage value, you might look at an Ambassador or a Fiat, but coffin spring 2021, I would say no to it. No to it. There are so many beautiful night tie expanders and lots of stuff that has come in. I would say no to that 038 thick wire coffin spring, which we used to do in your wire bending 30 or final year. Not anymore. Not anymore, I would say, as a practitioner.
Thank you, sir. Posterior scissor bite correction, role of expanders.
What is that?
What is the role of expanders in posterior scissor bite correction?
No, scissor bite correction, it's already scissored. You can't do any more expansion. So I think the person got it completely wrong there. If I got it wrong, come to me personally in WhatsApp. I'll try to help you. Scissor means it's already scissored out. So you can't expand it. It's already out. Scissor is out. So I don't know. I didn't get the question. Sorry about that.
If the oral hygiene is poor, expansion is preferred or not?
If the oral hygiene is poor, I wouldn't recommend any interceptive appliance at all. So first and foremost, Dr. Joby has been yelling about the importance of oral hygiene and the fluoride therapies and all that before doing all this stuff. So oral hygiene is important. You got to get the patient understand the importance of reducing the sugar level, brushing the hygiene part and all that before going into all these appliances. But SME is okay. RME, do not even try if you feel that the patient is not good in hygiene part or if the caries index is high. Do not try RME at that point of time. Wait for like 3 to 4 months till you get the complete sealing done, fluoride therapy done, go for RPE. SME is okay, it's removable anyway, so it's okay.
Thank you, sir. We have a question on YouTube as well, and we'll be taking one last question after this.
Sure.
When can we appreciate the opening up of the mid-palatine suture in a radiograph, sir? What are the chances? What are the chances of suture not getting split up and only the teeth keeps moving?
Oh, very high chances. So there are two parts of the question. First part is, when can you see the mid-palatal suture opening up in there? So the moment you see that the central incisors having a smallest of the gap, that is an indication that it has worked. Dentoalveolar expansion will not produce a midline diastema, period. So if there is no diastema and you see the molars going like that, either the turning sequence is not going good. Ask the parents, are you turning it daily, morning and evening? Yeah. Every day, morning and evening, we are turning. But last 3 days, no, he got some fever and he was he had a project in school and we couldn't turn. Oh, come on, that's not the way to go. Myself and Dr. Joby make sure that these RP cases report every day, night before going to bed through WhatsApp, a picture of this area every day, night. By that, you're doing two things. One, increasing the seriousness of the patient. Two, you can actually know what is going on. So you have to increase the seriousness of the patient. So the first part of the question, diastema, within 5 to 7 days, if you see a 0.5 millimeter to 1 millimeter diastema forming success, there is an opening up of the mid-palatal suture. But you don't have to take an X-ray that day. I would suggest after around 9-10 days, you take an X-ray. You can actually literally see the opened up mid-palatal suture. Second part of the question, can you say that again? Second part, those are the second part for the question.
Yes, sir. What are the chances of suture not getting split up and only the teeth keeps moving?
I think I covered that already. So if that turning sequence is not going perfectly, what is going to happen is the molars keep going like that. No diastema here. That means, oh, morning I did, but evening he had a Bible class and he couldn't do that. Next day morning he woke up very late, so we couldn't do that. See, that should not happen. So it is just the seriousness of the parents that matters there. I had patients coming in every day morning and evening to my clinic. Every day morning and evening to my clinic, because parents told clearly, doctor, we can't do all this stuff. Please, you do it. I will come every day morning and every day evening. So I do the turning. That has also happened. But now with this WhatsApp and video calls and all that, parents are doing it pretty good. On an average, they are doing it pretty good.
Thank you, sir. And that is up. We are concluding the session with a long, extensive FAQ session. It was an excellent session. Thank you again to all the participants for supporting us here. And all the questions or the queries can be answered on WhatsApp group. So feel free, do not hesitate to question there. All the questions will be answered very shortly. Thank you. And we'll be seeing you in the next session of expansion. Thank you. Have a good night.
Thank you all. Thank you all for coming in. Good night and happy Independence Day.